Dear audience, again, welcome. I'm Mariangela Pellegrini. I'm the Educational and Patient Program Manager for the ERN-EuroBloodNet European Reference Network on Rare Hematological Disease. So I'm really happy to welcome all of you on behalf of the ERN. So today, as you know, we are going to assist to a webinar that is part of the Thursday webinar. This was indeed the first program launched by the ERN for training physicians and for promoting the interest on very innovative topics among hematologists, pediatricians, and all health professionals on the advances in the field of rare hematological disease. And indeed, the scope of the Thursday webinar is yes, to address very rare disease, but to address the cutting-edge knowledgement and achievement in research for those rare and complex disorder or highly specialized procedure, or sharing the new guidelines recommendation. So before arriving at today's lecture, I would like to share with you some home rules. So first of all, as you can see, this session is recorded because the video will be implemented in our e-learning environment, so website and YouTube. And also, so if you feel not comfortable with that, you can change your name in the platform or switch off your video or just notifying it to me, and I will take care that you will not appear in the video. Your microphone will be muted along all the presentation, but at the end we will have a Q&A session. So you can both write your question in the chat, or you can raise your hands and I will allow you to unmute yourself and you can take the floor for sharing your comment, feedback, or questions. We will have this moment at the end. And so I think I said all the home rules. So I'm really happy to announce today's lecture. They will be on Pyruvate kinase deficiency, clinical management, place of Mitapivat in the guidelines and the organ damage guidance. With us, we have the Professor Eduard van Beers. He's a hematologist at the Center for Beginning Hematology at University Medical Centre of Utrecht in the Netherlands. And he specialized on rare hereditary hemolytic disease such as PKD and sickle cell disease. His department is appointed by the Minister of Health of Netherlands as a national center of expertise on treatment and research of rare anemias. And among other things, Dr. Eduard van Beers is currently involved in the PKD NHA study and the PEAK Registry and RHDs Initiative too. So I'm really honored to pass the floor to this key expert on PKD. So thank you very much. The floor is yours.
Thank you so much, Mariangela, and also for the invitation to present today to you the place of MIDA in guidelines for PKD and some guidance on organ damage screening and maybe treatment. And I think this title is very interesting because it states guidelines, but as you all may know, there's only one guideline and it's out for a couple of weeks only on Lancet Hematology. So this will be the first international guideline for PKD, and I'll walk you through in this webinar. So I hope you enjoy this, and in the end we can have discussion about the topics discussed. I have conflicts of interest to tell you, and most important is that I'm an advisory board of Agio Pharmaceuticals, and I have had research support from Agio Pharmaceuticals. And this is important because they are the producer of the product we are going to discuss, MIDA or Mitapivat, but I will call it MIDA because that's easier. As said, I'm associate professor in Utrecht. I'm also coordinator research and trials benign hematology from EuroBloodNet and try to improve the IIT environment in rare hematological trials. With that, we launched a first trial with Andreas Glentoy as PI using Mitapivat in other rare anemias such as hereditary spherocytosis and xerocytosis and CD8 type 2, which will update you on EHA, where EuroBloodNet is the sponsor of this. And you can do this too, so please contact me or EuroBloodNet leadership to find out how you can implement academic trials with our environment. Next to that, I'm clinical trial and innovation lead of my university to improve also clinical trialing in my hospital. And last but not least, I'm chairman of the Sickle Cell Outcome Research Score Group in the Netherlands, a group of experts in sickle cell disease in the Netherlands, starting a registry and research along that in collaboration also with EuroBloodNet and RHDs. Today I'm going to talk about the guideline, and I'm not going to discuss backgrounds of pyruvate kinase deficiency. Most of you will be familiar with this. If not, I recommend you to look up the previous Thursday webinars on pyruvate kinase deficient clinical management, where we'll discuss more on epidemiology and pathophysiology of PKD. And because diagnosing PKD is very tough and has a lot of pitfalls, I am not going to discuss this either today, because there's also excellent Thursday webinar from EuroBloodNet on the website, which is done by Paola Bianchi a couple of years ago, where most recommendations, which are also in the guideline, are highlighted in this webinar as well. So the outline for today is generally a walk through the guideline with a short introduction, and then a short note on diagnosis and genetics, because there's a webinar about this. And then we go into chronic complication management, anemia management, advanced therapies, and a short note on special populations. You can find these recommendations easily back on the Lancet Hematology website, where they're listed in tables and they're summarized in A1 to A5 until E1, E2. As said, you can find this on the website of Lancet Hematology. And this international guideline was coordinated by Hani El-Samkari and Rachel Grace, who put a group of internet experts together in working groups on specific topics to make these international guidelines coming true. And this is the group of experts who collaborated with this. And I'm very proud I have been part of this very energetic group, and it was great fun to do this. But most of the heavy lifting, as said, has done by Hani and Rachel. So thank you very much to include all of us. You can see also a large number of European experts were involved, and also 2 patients, Carl Lander and Door Pierboom. I'm very grateful that they could join as well. They are very knowledgeable of the situation of the patients. Their advice is very helpful, and I'm really happy that I can work with you in other PKD communities as well. So just as a short introduction, I want to say that pyruvate kinase deficiency is the most common cause of chronic congenital non-spherocytic hemolytic anemia worldwide. So if it's not spherocytosis and if it's not hemoglobinopathy, then chances are the patient who is in front of you with hemolytic anemia has PKD. And I want to stress this, because from the registries worldwide, from the PEAK registry and the PKD natural history study, but also from new epidemiological efforts from EuroBloodNet, which are done in RHDs, we find that a lot of PKD patients are still missing. So if you have patients in your outpatient clinic with chronic hemolytic anemia, where their diagnosis is not very clear, maybe you have to consider PKD again. And lastly, I want to state here that PKD can be very mild, but obviously, if you have more patients, you know that it has severe impact on health, quality of life, and mortality of our patients, with specific chronic organ damage arising when age increases as well. So I'm happy that we now have a new compound available for these patients. The goal, therefore, of the international guideline was to develop evidence-based guidance for clinical care of patients with PK deficiency, and also to help you to convince your national authorities and maybe your hospital authorities why specific care is needed, such as MRI, DEXA scanning, or implementation of new therapies or transfusion therapy. We have compiled these clinical guidelines using great methodology and agreed-to framework. But I have to say to you, as you can imagine, with a rare disease such as PKD, there's not a lot of evidence available. So almost all recommendations are low or moderate evidence, except for the two recommendations we have done based on the phase 3 trials, which obviously are of high methodological strength. And I'm not putting the grading in the slides, but where I say recommend, it's a strong recommendation from the experts. And where I say suggest or consider, it's a weak recommendation. But most recommendations here are strong. So very short on the first table in the guideline, which is about diagnosis, I want to stress two things. One, please test for PK deficiency in all patients with non-immune hemolytic anemia after exclusion of hemoglobin disorders and erythrocyte membrane disorders. So as I said, if it's not spherocytosis or another membrane disorder and no hemoglobin disorder, then think about PKD. We are still missing patients given the number of patients in certain countries where there's a stringent and free for all screening program, such as in the Netherlands, compared to other countries. And then lastly, I was going to highlight that predicting disease severity cannot be done by enzyme activity. Enzyme activity can be helpful to detect patients, but also there are pitfalls. I'll come to that later. But it certainly does not help to say anything about severity in your patient. So in a sense, this is the same as the WHO guidance on G6PD. Recently, the G6PD guidelines were updated by the WHO working group, and they also state do not use G6PD enzyme activity for clinical prediction or any clinical saying. We use this for epidemiology and for diagnosing, not for anything else. And then last but not least, I want to say this everywhere where I talk about PKD. The biggest pitfall in PKD diagnosis is that patients with PKD deficiency, even with moderate to severe hemolysis, can have normal PK activity. So please put that in your mind, and you can go back to the guideline what to do. You can go back to the Thursday webinars from Paolo Bianchi what to do, but put this in your mind. PK activity is not always enough. So now we move on monitoring and management of chronic complication of PKD. So recommendations B1 to B10. And here I highlight the key messages. Vitamin D monitoring. We recommend annual vitamin D measurements starting at the age of 1 year in all patients not on regular vitamin D supplementation to detect and treat vitamin D deficiency. I think this is a very good example of what a guideline is doing and what the guideline is suggested, because we suggest where there is evidence. But I think this also implies, and that's what I do in general practice, that you obviously also test patients who are on vitamin D supplementation for various reasons. One, the patient might not take the vitamin D, or two, you don't give enough. So just measure it and start early on. Then the next recommendation, bone mineral density screening. We recommend screening for reduced bone mineral density using DEXA scan starting from adult age to diagnose and manage osteopenia and osteoporosis. I think there's good evidence that it is helpful to scan adult patients. For children, we don't have enough evidence to give guidance. Also, because there's no good guidance what you have to do if you find osteoporosis, which is easier in adult patients. But at least do scan your patients. Endocrine function monitoring. We recommend age-appropriate laboratory endocrine monitoring in patients receiving regular transfusions and those not receiving regular transfusions, but with iron overload, to identify and treat endocrinological complications. This is also based on the prevalence of diabetes, thyroid problems, and other endocrine problems in PKD, which obviously are related to iron overload, just as in thalassemia. And I think we also leaned here in on what's available in thalassemia and other rare anemias with iron overload. And it makes just sense to follow these patients and treat patients for endocrine disorders if there's iron overload. So a strong recommendation, not so strong evidence. Also, for renal functioning, we suggest, which is a weak recommendation, to monitor renal function in children and adults with PK deficiency, irrespective of transfusion status, for early detection of renal dysfunction. And I think this is because the practice varies between countries and hospitals, but it could be helpful to be early in finding nephropathy or renal dysfunction, because there are general guidelines how you can treat this. And the prevalence in PKD is not as high as in other rare anemias, but reasonable enough to give a low strength suggestion. Now we come to a more complex topic, and also more important, I think, on iron overload. We as a group recommend to screen for iron overload with serum ferritin in children and adults with PKD starting from age 3 or after 12 transfusion episodes, whichever comes first, regardless of transfusion status. So this is, I think, an easy statement, easy to do, but we have found that in the PEAK registry and also in the PKD natural history study, in many patients there was not an MRI available, but also in many there was no ferritin available. So therefore this recommendation as a kind of underline what you have to do. And then we also give a recommendation on MRI. We recommend to measure liver iron content using MRI in patients with consistent serum ferritin levels above 500 to detect hepatic iron overload, irrespective of transfusion status. I think that this is conservative, and I completely agree with this. And I will put this in perspective in the following slides. And I think here also the wording is important, because we recommend to measure at least in those patients with the ferritin above 500. And also, it doesn't matter whether the patient has had transfusion or not. I think if you look back in the other webinar, but any other publication in PKD on iron overload, we have seen again and again that transfusion status does not say anything about moderate or severe iron overload. Then additional statement about cardiac iron overload monitoring, and then we follow general guidelines which are available for other rare anemias as well. We recommend to perform cardiac iron measurement using MRI in patients with a LIC over 7 mg per gram dry weight to detect cardiac iron overload regardless of transfusion status. So this is a subgroup of the former MRI, but I recommend, if you're not doing it together, to discuss this with your radiologist, because combining LIC and a cardiac T2 star is very easy to do. It doesn't take up another MRI slot. They are the fastest scans you can do, because you don't have to do this anatomic evaluation. You just take a region of interest and measure the grade of the tissue. So in my experience, I always do them the same, because it doesn't add anything to do it separately. So I screen everybody with cardiac iron overload. This is not a medical advice. This is operational advice. So let's continue. Iron chelation therapy. We recommend iron chelation therapy for patient aged 2 years or older with a liver iron content over 5, irrespective of transfusion status, to reduce the risk of iron overload complications. So obviously there's no evidence in PKD for this, but we follow here several guidelines which have been published in thalassemia and other rare anemias, where liver iron content threshold for initiating therapy is getting lower and lower last years, and we chose to go for 5. We suggest, which is a weak recommendation, iron chelation therapy for patients aged 2 years or older who have received 12 transfusions or have serum ferritin concentrations over 1,000 nanogram per mil. This is an area with no evidence, but we felt we had to say something for areas in the world where there is no MRI available. We had a number of discussions about this, but the cutoff of ferritin of 1,000, I think, is a good cutoff because it's very specific for iron overload. Do you miss patients with this cutoff with iron overload? Yes, for sure. You even miss them with 500. Come back to that later. But at least this is a conservative thing, guidance that you could use to initiate therapy if you lack MRIs. Pulmonary hypertension screening. This is also a weak recommendation. We suggest to perform cardiac ultrasound in all adult patients with PKD to screen for pulmonary hypertension and possibly other cardiac modulation based on chronic anemia lifelong, which could be cardiomegaly, mitral valve insufficiency. So all these things we see in other rare anemias as well. This is interesting. It's weak. It's low evidence, of course, and it's contrasts with recent guidelines in sickle cell disease. But we don't know how prevalent pulmonary hypertension is in PKD. But in our registries, PK natural history study and the PEAK, we see a number of patients with pulmonary hypertension, obviously because it's an anemic hemolytic group of patients. With a lot of them are splenectomized, which are all risk factors in general for pulmonary hypertension, but not a lot of evidence, so we suggest to do it. I want to highlight also some things we give for granted when we treat a lot of patients with hemolytic anemia, and I think that's giving the patients folic acid. And that's interesting because the expert panel was also not able to make evidence-based recommendations regarding the use of folic acid in PK deficiency due to the lack of evidence and diversity of clinical practice. And of course, yes, we know this, there is no evidence for it, but it makes sense because if you have reduced folic acid, it will hamper your availability to maintain hemoglobin in the patient, and it could worsen the situation. So we cannot do a recommendation here. A lot of people do it, and I would say, no, check it and supplement it when needed, or just supplement it. I also want to remind you that all clinical trials with MIDA, which have been done in sickle cell disease, thalassemia, which are now being conducted in spherocytosis, and which have been done in PKD as well, they are all on strict support of folic acid of at least 0.8 mg per day. So you can also say how that it's needed if you start MIDA. We don't recommend it, but it's good to have a thought about this. These kind of afterthoughts you can find also in the supplemental material of the guidelines. What is not in the supplemental material, but what I do want to highlight, inform you about, is that in the year that MIDA was trialed in PKD, there was a second randomized placebo-controlled trial, including patients with PKD. So which was the second randomized placebo-controlled trial in PKD ever published, which was the PPI Shine Again study, which was published in the American Journal of Hematology by me and co-workers from the Netherlands. And we trialed placebo versus twice daily 30 mg of esomeprazole to reduce gastric acid and iron uptake. And we found a statistically significant clinical meaningful difference of 0.5 decrease in liver iron content per year in favor of esomeprazole. So esomeprazole is very cheap, low side effects, and it can help reducing liver iron content in a basket trial, including a number of PKD patients. So in my opinion, it's good to know this and consider it as an adjuvant in case of intolerance or other reasons for unavailability of other chelators. However, we cannot state this as a recommendation as it was not a PKD true trial, but it's good to know that it's out there and could be helpful. And also, this trial was sparked by funding from the government in the Netherlands, based also on the experiments of Dr. Hans Morton in Pennsylvania. He's treating a very large cohort of patients with PKD from the Amish population who had problem getting access to exudate and chelators. And he was treating with proton pump inhibition as well and citrate. And surprisingly, in this fairly severe group of PKD patients, we didn't find that much of iron overload. All these patients got an MRI in the PKD natural history study, which was led by Rachel Grace. And surprisingly, there was low iron overload in this cohort, which sparked this Dutch trial. So I think there is historic evidence and there is a trial which could support the use of proton pump inhibition if there are no other options available. So coming back on iron overload monitoring, in the outside of the main text in the supplements, the expert group discussed the clinical utility of screening for iron overload with both ferritin and transferrin saturation, but concluded that the transferrin saturation would increase the sensitivity of screening, but decrease specificity, particularly in infants and children and those in hereditary hemochromatosis. So this was a big debate in our group, and I agree with the recommendation, and I also agree with what is in the supplement. But I just want to highlight what happens if you only use ferritin above 500. So in table 3, I show you data from Dutch SCORE collaborators. It was a study outside of the SCORE group because it included mainly PKD patients and other rare anemias. We collected 112 patients, which we had MRI available from 3 large centers in the Netherlands, and looked at the sensitivity of ferritin versus transferrin saturation and ferritin. And you can see here that if you look for mild iron overload and you use a cutoff of ferritin, then you're only able to identify correctly 41 of those patients. If you use a threshold which is stronger, so a lower ferritin cutoff, you find 76 patients with mild iron overload. But if you combine it with transferrin saturation 45, this increases to 87. However, maybe more important is the group with moderate iron overload with the liver iron content above 7, which we do recommend to do cardiac screening as well because they are at risk of cardiac iron overload. If you use 1000, the sensitivity is only around 60%. So 4 out of 10 you will miss. If you use ferritin 500, it's 1 out of 10 you will miss. And if you use ferritin combined with TSAT, you will find them all in this small group. So this was a mixed cohort. Yes, I agree with you. So I looked back in our PKD natural history study and looked into ferritin measures there as well. And this is taken from the PKD natural history study iron overload paper in 2019. In this graph here, you see ferritin on the x-axis, and on the y-axis, you see embryonic liver iron content. So important cutoffs are 7, because that's identifying moderate iron overload, 3, which identifies mild iron overload, and maybe 5, because that's the threshold where we initiate chelation. In the group under 500, you see that there's at least 1 with moderate iron overload and at least 2 with a liver iron content above 5 who should get chelation following the guidelines published here. So that's 3 out of a number, but you have to think about whether using transferrin saturation or not. So I agree with the guideline, ferritin cutoff, you have to do that, but we do not say don't use TSAT, and I recommend you to think about it. Is there another guidance to help you implementing transferrin saturation? Yes, there is an excellent Hematology Association educational program paper from Kleber Vertrin from Seattle, USA, who has reviewed all trials in inflammatory disorders who investigate iron overload or iron deficiency, and he came up with this very helpful table and uses cutoffs which are used in many guidelines and for several diseases. And here you see transferrin saturation, and here you see ferritin. And you see that above ferritin, the risk of iron overload is high, which we use in this guideline as well. But also here you see if transferrin saturation is above 45, there's also high risk for iron overload, irrespective of ferritin. And in my clinical practice, I can tell you I've seen a number of patients with ferritins even in normal range, so between 100 and 200, with moderate to severe iron overload. So it's something to think about. Then we move on. So recommendations on clinical management of anemia and PKD deficiency. Not many has changed here, so this is also not a lot of evidence, but strong recommendations. They are all recommendations except for consider. So obviously we recommend to discuss splenectomy in children over 5 years. And discussing splenectomy, in itself is a weak recommendation. We don't say do it, but we say discuss it. I think it's a shared decision making as example. And especially now MIDA is available. We come to that next. So for red cell blood transfusions for young children, we recommend to initiate transfusion in children with symptomatic anemia or anemia that gives failure to thrive, which are no changes before and compared to other guidelines. In older children and adults, we recommend for symptoms to initiate it, who have had splenectomy or don't want to have splenectomy or unsuitable for splenectomy. So also, enough room for you as a clinician to do what is in best interest of the patient. As transfusion criteria, we recommend against a hemoglobin threshold. So look at your patient individually. And this is coming from a traditional standpoint that in PKD, patients tolerate lower hemoglobins than, for instance, patients with thalassemia because of many pathophysiologic differences between thalassemia and PKD, which I'm not going to discuss here. But I think that you have to look, you do your organ screening, you see how much problems there are. Is the patient able to work? And you sit down with the patient, what's best? Could it be splenectomy? Could it be transfusion criteria? At least we give here this guidance not to use one threshold for every patient, and I cannot agree more with that. Also, on top of that, in my experience, younger patients can have lower hemoglobins than older patients. And in contrast to thalassemia, where we now know that lower hemoglobins are also associated with more complications, we don't have this clinical picture now in the PKD. So therefore, we could not recommend any threshold for PKD. This is also an argument if you are discussing this with thalassemia colleagues, why we don't have these thresholds in PKD and why PKD patients are a little bit different from thalassemia patients. Then some statements on splenectomy and cholecystectomy. Consider a weak recommendation to remove the gallbladder if you do a splenectomy, if there are signs of gallstones or biliary sludge. Otherwise, you can go in for surgery within 5 to 10 years again, because the coexistence of these problems are very high. And lastly, we recommend to offer appropriate psychological support in children and adults with PK deficiency and their families and caregivers. You cannot overestimate the burden of the patient, especially in young families. So now what will be the new thing about this guideline? Well, the whole guideline is new because it's the first guideline, but the new thing here is what are we going to do with MIDA? And I think that here it's difficult, but also easy because we have these phase 3 trials in open label, phase 3 trials in transfusion patients. So as group, we recommend to start MIDA in adult patients, because the pediatric patients are in trial right now. So in adult patients, we have the evidence. Start in adult patients with PKD who are anemic, not regular receiving transfusions, and without 2 non-missense mutations. To remind from the trials, having 2 non-missense mutations will result in no expression of the protein, and the drug works by binding to the PK protein. So then, now in these patients, there's no chance that the drug will work. So, and we also recommend to start regardless of splenectomy status, and the goal is to improve hemoglobin levels and or quality of life. We come back to that later. How do you determine whether a patient is responsive or not? We recommend you to consider, so this is you read here consider, but it's a strong recommendation. We recommend you to consider patients non-responsive to MIDA only after at least 3 months of treatment on optimal dose for those not receiving regular transfusions. Because if you give MIDA in patients on regular transfusion, it's much tougher to see treatment response, because you have to count bags of blood given in transfusion instance, because that's a primary endpoint in those trials. In patients not getting transfusions, it's easier because you can follow quality of life, you can follow iron overload, you can follow hemoglobin. But do remember that we have seen patients only responding after a couple of months. So don't quit after a couple of weeks, because most patients respond after 2 weeks. We recommend against that. We recommend to try it at least 3 months on optimal dose. Then, what about MIDA and regular transfused patients? So this is a moderate evidence but strong recommendation. Begin MIDA in adult patients with PK deficiency receiving regular transfusions and without 2 non-missense mutations to reduce transfusion burden. So the goal is reducing transfusion burden. Back to that later. Then, when to discontinue MIDA in non-responders, we recommend to stop MIDA and return to supportive care in patients who do not respond to treatment, irrespective of the transfusion status. Seems very simple, but I think it's good to have stopping rules in guideline. So then we continue with some other recommendations. We recommend to consider alternative treatments or clinical trials for patients not responding to MIDA. I think that's a very reasonable, easy recommendation. And we recommend to continue MIDA in transfused patients only if there's at least a 33 reduction in transfusion requirements, unless significant improvement in iron status, health outcomes, or other disease parameters are observed. So what we're saying here is that you need a reduction of 33% of transfusions in order to say, okay, this is really good. Continue with the drug. But we leave room, and we have seen this in our patients on trial. If a patient has a reduction, for instance, of 25% of transfusion burden, it might not be that significant for a trial, but it can be very significant for a patient, because it means a reduction of iron burden of 25%, which can tip the scale of the iron balance from positive and only increasing, and then a certain amount of complication and death after a couple of years, or when the transfusion balance is getting negative because there's a reduction of 25% of the transfusions, which will mean that the iron overload will come down with less complications and a better outside. So therefore, we felt we have to be a little bit more broad than the 33 threshold, which was the primary outcome of the trial. Next, MIDA before splenectomy in transfused adults. We recommend a trial of MIDA before considering splenectomy in adults receiving regular transfusions who have not undergone the procedure. I think it makes sense if you can save a splenectomy in the patient. Why not? Long-term outcomes, splenectomy, I think is worse than many people think. It's associated with a lot of thrombosis, especially when patients age. And now the whole group of PKD patients is getting older. We have to see what the side effects of splenectomy are on long term. I've had discussions with a couple of pediatricians who did not recognize this thrombosis risk. But I think the risk of doing something in childhood, sometimes you pay the price in adulthood, and that's something we should not forget. I think you can also do a splenectomy instead of trying MEDA. This is really also a personalized medicine approach, but we recommend at least to consider this. We also suggest, which is a recommendation, to use PK deficiency specific quality of life measures, because if you don't use them, it's very hard to find differences in quality of life if you want to quantitate it. We find difficulties in a number of rare anemia trials, and some of you might also remember the failure in luspatercept to find a difference in quality of life. Maybe it has to do with the drug, but it could also have to do with how difficult it is to measure quality of life in these patients. Just as an example, I had a patient that went on transfusion therapy and felt much better. And I asked her after 2 years, how's your life now? And she said, well, it's so much better. I'm so grateful for you. My life is now a 7 out of 10. And then I looked up in my patient chart and I reminded her, it was a 7 out of 10 before you started the transfusion as well. So it didn't improve. And then she looked at me, no, it wasn't a 7. It was a 3. It was a 3 out of 10, I'm sure. But her background on quality of life changed after improvement. So it's very tough. And at least we have a weak recommendation. We suggest to use specific quality of life because they're more sensitive. So this is the last slide of the guideline. Some recommendations for special population in PKD. I think that we recommend to ensure children and adults with PK deficiency are regularly monitored by a hematologist, regardless of their transfusion status. We have seen a lot of comorbidities in non-transfused patients, and when they age, they run into problems. They need transfusions, which they didn't need before. So I think this is a strong recommendation. For the care for pregnant women, we recommend to refer women with PK deficiency, whether pregnant or planning to become pregnant, to a multidisciplinary fetal-maternal team that includes a hematologist, obstetrician, neonatologist, and all the relevant specialists to minimize maternal and fetal complications. We have seen a lot of complications in during pregnancy in patients with PKD, which really warrant some additional care. Also, anemia tends to get worse during pregnancy, and there's fetal complications which warrant observation, and maybe you have to discuss whether you have to install transfusion. Obviously, there's not a lot of evidence here, but I think it's good to discuss this with a team with experience with PKD, or at least other rare anemias, because this is a period with a lot of complications. So this concludes my walkthrough to the first ever guidelines in PKD, and I'm very grateful to be part of this endeavor, and I'm also very happy that now we have some guidelines which can help us advocate the care we every week give to our patients. And I once again want to highlight all the authors who have collaborated in this. I had a lot of fun, and also shout out to Hani El-Samkari and Rachel to bring the whole PKD community together and get this first guideline done and published. Well done, and thank you so much for your kind attention. And with that, I stop sharing.
Thank you very much, Dr. van Beers, for your comprehensive presentation. So before checking if there are some questions, and please feel comfortable in unmuting yourself and take the floor or write a question. So I would like to advertise also the video I think you did in 2021, the lecture that was on Pyruvate kinase deficiency in clinical management. So if you want to see the before and after the publication, so I think it could be a good exercise. So I'm putting it in the chat. And also on our website, you also have the link for the presentation. So I'm putting those in the chat. So let's see. Do we have any questions? So if you want to unmute yourself, the process is raising your hands or just take the floor. So we have one comment that says, very interesting presentation. I echo the same. I'm putting the presentation.
Sorry, can I ask a question?
Sure, please.
Hi, everybody. I'm Simone Villaboni from Verona, Italy. And ask you also thank you for the brilliant presentation. I want to ask you, Professor, what do you think about the use of Mitapivat in other hemolytics anemia? Not all. Yes, that's like in thalassemia with energize T. I think study it's very useful and interesting drugs to our patient. I really want to think what you think about it.
Well, thank you so much for this question, Simone. Yeah, I've worked with this drug now, I think maybe 5 years, from the very first time in PKD and then in the thalassemia and then back again in PKD randomized trials, also 2 studies in sickle cell disease, and now we do it in spherocytosis and congenital dyserythropoietic anemia type 2, and also in hereditary xerocytosis, so the PHL1 mutation. And I think, it seems like a boon for all, because these patients all have a different molecular defect. So they all have red cells, like, if you see them like a floating boat in a water of plasma where they have to survive, and they all have different problems. The one has a broken motor, the other have broken sails, and the water's coming in. But Mida is just giving those red cells energy to fight what they need to fight and extend lifespan. And if you can extend lifespan in hemolytic anemias, that will improve the situation of the patient. And I think what the good thing here is that in all trials, Mirta van Dijk, PhD from me, has reviewed this recently in Blood Reviews, that if you look in the table of preclinical and clinical evidence, you see again and again that Mida does the same thing. It increases hemoglobin, it reduces reticulocytes, it reduces hemolytic parameters, and it reduces EPO. It reduces iron overload. So it really improves the hemolytic phenotype in all these patients. While it doesn't address the molecular defect itself, it just is a life-saving something for those red cells, giving them energy to cope with the disease they have. So this is my opinion based on what is done before. Obviously, I have worked with the company in a lot of trials. That gives me a lot of insight. But I'm sure it will be a success. Unfortunately for PKD, interestingly enough, the PK activator is in itself not so efficient in PKD, because in PKD, at least 1/3 of the patients have double non-missense mutation, which means there's no PK to activate. So a PK activator will not work. So in a sense, we were lucky in the first trial that there were enough patients with with missense mutation who responded to the therapy. Otherwise, this would not have happened. Just as a reminder, Agios Pharmaceuticals started out to find a PK inhibitor to treat cancer. It was a cancer company. And now it's a rare anemia company. And I'm very happy with that. And I hope we can extend these trials to many more rare anemia patients who are still out there having problems with their anemia and quality of life. Does that answer your question, Simona?
Yes, thank you. It's an amazing drug, an amazing oral drug. That's making a difference. That's make a difference for the patient. Thank you.
So thank you very much. We have the time for a last question, if any. So please do not hesitate to write it in the chat or by unmuting yourself. Or also it could be on the other way around, Eduard, if you want to ask something. Because maybe you are also interested in other practice or in having some colleague point of view.
Yeah, we should have done a kind of voting system or something like that, because I was very interested to hear if people find that there are some surprises in the guideline. I think in general guidelines are, you have to stick to evidence. That's why transferrin saturation is not in there. But I just want to highlight that it's out there, and maybe, I was interested if there were new things people were surprised about.
No answer should be a consensus, in my opinion.
It is a better group than the group we discussed the guidelines with. Not so fast consensus, but it was fun. Okay.
Okay.
Thank you so much.
Thank you so much to you, Eduard, for this great presentation and for having shared all your knowledge and this cutting-edge information on PKD. And so thank you very much. Having a nice evening.
Thank you so much. Bye-bye.
Bye.